Hello, everyone, and welcome to the Climbing Majority Podcast. Max Carrier here, one of the co-hosts. Quick message before we dive into the episode. If you've been enjoying the show, please rate and review us on Apple and Spotify. Also, consider sharing this podcast with your climbing friends. Word of mouth is a powerful tool to help us out. With that housekeeping out of the way, we can get into today's episode. In today's conversation, Kyle and I have a conversation with Kevin Wright and Matthew Oravitz. They are both occupational therapists that reside in Reno, Nevada. The topics that we cover include rehabilitation, injury prevention, strength training, muscular imbalances, and much more.
Wicked, man. Yeah, well, just speaking for myself, like pretty stoked to have you guys here and, ready to have a nice, good conversation and stuff. And, generally for us, I think a good way to go about this is to just, give yourself kind of a brief introduction of, like who you are, where you're from, and maybe some of your credentials and, and then go from there.
Yeah, sure. All right, so I've been a PT for about 9 years. I graduated up in Spokane, Washington, where I've been working for the last little bit, and mostly got into PT for the sports-oriented stuff. Grew up an athlete my whole life, played all the sports under the sun, but mostly focused on basketball. Haven't really done a whole lot of climbing, but I've treated a handful of climbers because where I worked in Spokane, I helped run kind of a strength and conditioning gym that also had physical therapy and basketball training in it. But across the street was a climbing gym. So we got a lot of patients from there. You guys were good for business, which was, but it was a good way to get involved. It gave me a good experience to know what types of injuries climbers sustain, learn some of the terminology, some of the techniques, some of the goals of getting back into it and stuff. And it was really fun because it was we could just go across the street. They can clock in for their PT session, and we go across the street and climb. We'll get into some stuff later about how good climbing is for low back pain and low back injuries. So we really kind of use that as an excuse to get over there and have fun for 45 minutes or an hour. So so about 9 months ago or so, moved down to Reno, where I am now, and accepted a job with Northern Nevada Rehab and Sports Medicine. And been kind of working there for the last little bit and starting to develop kind of the sports medicine niche, getting to know some doctors in town and getting some referrals from different club sports and stuff like that. And enjoying it.
Hey, Kevin, I just have a quick question. When you went over to the climbing gym, did you ever do a treatment, do a pre and post test to see the value of the treatment that you provided?
Yeah, it was really interesting. Like in the PT world, we have these things called asterisk signs, which is you do something that normally hurts the person, right? Or not doesn't hurt, but causes some pain, right? So let's say someone with back pain, you haven't reached down and touched the toes. Like, it kind of causes some pulling or pain in my back. And, you haven't put a number on it or whatever. And then the idea behind an asterisk sign is then you do some techniques, whether it's a manual therapy, hands-on stuff, some exercise, some type of stretching, and then you have them redo that movement and see if they feel better, worse, or the same. And that really kind of dictates your path of treatment. Specifically for backs, we'd go over there and, all right, man, let me see you, extend and rotate, if that kind of hurts, let's go for, a good 5 minutes on the wall and get some muscles firing and then come back down. And not every time, but a lot of times they do that same extend and rotate or the same move that hurt in the first place and it'd feel better. So it was really pretty fascinating to see some of that research that's been done about how climbing can treat low back pain and then actually see it in front of your eyes. So it's pretty cool.
Yeah, I don't want to jump ahead or anything, but the one thing to emphasize kind of going forward is, when we talk about diagnosis and specifically pathoanatomic diagnosis, where you're like, oh, that hurts there, the pain is associated with this structure, is actually quite unreliable in across all disciplines, physicians, physical therapists, chiropractors, you name it. We are very poor at that as a discipline, and that's not provider specific. So it's always interesting for us as a profession and very powerful to, have something that was bothersome, do an intervention, and then see that same action resolved. for a variety of reasons, some of which are placebo, some of which are unknown to us, but it is still a really powerful in treatment kind of sign that we're doing the right thing.
Yeah, and it's fun to see. It's fun to see the eyes kind of light up too of the patient, where they say, "Whoa, what did you just do?"
Yeah.
And sometimes it's as simple as we took the threat away. We made that movement not scary anymore. And sometimes we actually are influencing the tissue, but it kind of just depends.
How much of your work would you say is mental, and how much of your work would you say is physical, in terms of your effect on the person you're working on? Does that question make sense?
Absolutely. Mm-hmm. Yeah. You want to take it, Matt, or you want me to take it?
Yeah. So I can start off. I'll answer that question in a second. I can introduce myself. I'm Matthew Oravitz. I too am a physical therapist. I've been practicing a little bit longer than Kevin, about 13 years now. I've been sort of doing my own concierge private practice for the last 6 years, and then I do like basically home health, which is sort of geriatric care, but that one pays the bills. The private practice kind of feeds my mind, is how I kind of shape my work experience. I think the differentiating factor for Kevin and I is our fellowship training, and this fellowship training is a big part of sort of the fun in physical therapy. It's 2.5 years postgraduate work, and you get to work with mentors, and then you get introduced to this community of fellows. And that's actually how Kevin and I met. He reached out to me and one of my mentors, and then put us in touch. And now I've been lucky enough, for some of the patients I can treat, I've been able to triage them right into Kevin's practice, since it's insurance based, and it's been like a wonderful experience. My relationship with climbing, before we go into this, is I'm pretty active outdoorsman, similar probably to both you, Max, and Kyle. I started off like as a backcountry skier, and then did a bunch of like sort of ski mountaineering in the area. Northern Nevada and sort of California are known for their volcano seasons. So we have Mount Lawson and Shasta nearby, and kind of climbing was just a sort of progression from those like basic mountaineering skills. Kind of my interests are sort of these long moderates that the Sierras are known for. Comfortable 5/6 trad lead, kind of scrambling low class fifth, but prefer ropes. And I mostly do outdoor climbing at this point. Hardly any gym climbing, and as I said before, sport climbing is a little too hard for me from a kind of activity standpoint. But so that's my intro. Kyle, with respect to your question, I can jump on that first. I think it's a good mix, and there's something that we work with. It's called the biopsychosocial model, which I don't know. Have you guys heard of that?
I have. I'm familiar
Max,
with that.
Yeah. So, I mean, it's just sort of that intersection of all three of those. The biology of the problem, the sort of social aspects, self-esteem, family, blah blah blah, and then the psychological aspects of that. How do you approach a problem? Like, how do you see danger, and all of those things. So when we talk about treatment, I kind of think of it in a way that you have a number of hypotheses, right? So you have what's the problem is one hypothesis, sort of what's the pain generation is another hypothesis, who the patient is, what are their beliefs, and then what are their goals. And as you kind of go through your, hypothesis generation and then intervention choice, you have to slide each one of those kind of aspects up a little bit, and then down a little bit, and then up a little bit, and down a little bit as you go through it. So, I mean, it's hard to put a percentage on it, but I think it's more sort of patient specific, and that kind of gets into sort of repetition. Like, you can assume a patient or make assumptions on a patient just based on their interview. And that subjective interview is probably one of the more powerful determinants in regards to deciding what your intervention strategy is. Is it more exercise based? Is it more manual therapy based? Is it this sort of biopsychosocial aspect to it? I don't know, Kevin, if you want to add to that.
Yeah, I mean, I'd agree with all of that. I think another part that I really have learned to focus on over the last couple of years is really trying to get a hang of whoever's in front of you's personality, and if they are a type of person who sees an injury as just a bump in the road. They'll be fine. They'll get back to it. No big deal. They know they heal. They know they're going to get better. Versus the person who kind of tends to catastrophize a little bit. They feel like their injury is taking over their life and they have a hard time. They don't see themselves being able to get back. And you're going to treat those two people a lot different. I've really learned to become almost like a psychotherapist at times over a physical therapist, because sometimes people just need a lot of reassurance, reassurance. They don't think they're ever going to be able to get back to it. And that we know that people have different just anatomic nervous systems where, the pain signal comes into the spinal cord up to the brain, and we all have connections from our sensory part of the brain to our emotional part of the brain. Right. But some people have more connections, right? So they just have an exaggerated emotional response to an injury. Right. And you're going to treat that person with a lot more of a slow kind of progression and a lot of reassurance and kind of patting them along the way and celebrating the small victories and things. And so to answer your question, it's kind of a fascinating mix. The people that are go-getters, you can just push them, and just go crazy and kind of be blunt with them. The other people, you have to take a little bit more of a delicate approach.
Yeah, I was just say from a climbing standpoint, an analogy I like to use is your sort of exposure. So, for me personally, like I'm not that comfortable at heights when I walk right up to them. So if I start at the top and walk to a cliff, I get an autonomic response, sort of like the butterflies. I get nervous, like I'll get like sort of sweating where I shouldn't be. But if I were to climb up from the bottom of that same cliff and like get comfortable with that exposure, I don't have that autonomic response. And you'll find patients who come in and they're already having this sort of autonomic reaction that primes them for they call it allodynia and hyperalgesia. And so allodynia is typically your normal response to pain versus hyperalgesia is this elevated response to pain. And like you can get a sense of those things that kind of speak to Kevin and I's point.
I think that's such an interesting point you were talking about with like the biopsychosocial model, because, I think Kyle and I have talked about this before, where particularly to traumatic injuries, but I think this applies to like all walks of life and people in this kind of, genre, is that it's really easy to just myopically focus on like the actual trauma or the injury or the pain and really exclude that kind of like psychological or even that like social aspect, right? So it's like, it's so catered towards, okay, we're going to focus on the biological, but the psychological, like you were just talking about, I don't exactly know the terminology used, but the psychological could be amplifying the pain based on your response, right? That can be affecting your healing process, your injury. The social component to the model, who's in your support group, what is your diet, what is your nutrition like, what are the influences around you like, how committed are you to this? There's so many things that go into therapy and rehabilitation and training that I feel like or at least from my perspective, I feel generally when I talk to people are really overlooked. And I think a really common one that I've run into over the years with people is like, they'll be like, oh, I went to physio and, it's not really working for me or this or that. And then I'll be like, okay, well, like how many days a week are you on a foam roller? How many days a week do you use a lacrosse ball? Like, how many days are you doing the prescribed exercises? You can keep going down the list. And usually in my experience, I won't paint other people with the same brush, but my experience is people who are going through that, there's not a general level of consistency. So I'm wondering, how do you guys, you were talking about juggling those puzzle pieces in the beginning, right? And so to me, one of those puzzle pieces would definitely be on a psychological level, gauging like, how committed is this person? Like how much of what I'm saying right now is actually going to be followed through on? And so I'm wondering how you guys deal with that with your clients.
It's kind of funny because you would imagine the more high level athletic person is going to want to work the hardest. Not always the case, right? Sometimes these guys have just coasted on their ability, or gals have coasted on their ability and don't really have the work ethic or the mindset to really work hard at recovering. So I think you can gain a lot just from talking to somebody, just from taking your subjective history with these people, and you can get an idea of, they'll tell you, you'll get a vibe from it, and they'll flat out tell you like, I'm here to work, like I know it's going to take a while, or you get the other people who I was talking about earlier, where they're a little nervous, they're a little scared, they're kind of amplifying maybe a little bit, but pain is such a subjective thing. You don't really know exactly, what they're feeling. But yeah, I mean, it's definitely takes a little getting used to, and takes some experience as a provider to kind of be able to pick up on people's personalities. And I've also gotten a little bit more blunt with people, like, look, you're not doing your stuff. Like, if you want to get better, you have to do this. This isn't my knee, like this isn't my shoulder. I'm not going to babysit you, and try to check in all the time. Like, you have to have some accountability. And sometimes that gets people kind of tuned in to what needs to happen and gets them motivated.
It's easy not to do anything and blame the PT for your problems.
Yeah. I mean,
we get it from patients and doctors.
There's a bit of accountability that I sort of prescribe to. So statistically speaking, people are compliant with between 3 and 5 exercises. So, in that's like the kind of sweet spot that you want to aim for in order to get more compliance. And then sort of the other thing is, Kevin and I have a strong background in manual therapy. And when you think of physical therapy, a lot of people associate that with like hands-on things. And frankly, everybody loves to get hands-on treatment, right? It feels good. You can get immediate results. You can resolve, some of the acute issues really, really quickly. With that said, that has, with the evidence, sort of been shown to have a short impact, where exercise is ultimately going to be the long impact. And when I'm encountered with somebody who I think is somewhat non-compliant with their exercises and slowing down sort of their overall recovery, I'll take away the manual therapy component in their treatment and just go through their exercises, right? And that will reinforce the value of the exercise. And then I will use some manual therapy as sort of like the treat at the end, right? Versus kind of starting off with like what feels good, and they're like, oh, it's really valuable. I get value out of this. But that's how I would do it. And then I do tell patients this a lot, is that I'll shoulder the responsibility, because at some level, if everybody's failing the test, it's the teacher's fault. It's not the student's fault. And so I'll sort of bring them along that journey, and, along this sort of biopsychosocial aspect. I don't necessarily want to get too bogged down in it, because it goes a little bit beyond. And I always try to remind people there's a physical before the therapy, because sometimes people want to talk a lot, and so you just have to sort of work your way through that. But I'm kind of losing my train of thought, but it's an alliance. And so what has to happen is the patient themselves has to feel like you're on their side, and you're going to journey with them through it. And I think when you guys kind of talked about all of this acute injury stuff that you've gone through, and all these surgical consults and the surgery themselves, Kyle, when the surgeon is done, and this is no criticism, they're like, hooray, I did a great job. And then they just like, you're out the door, go see your therapist. So you need someone to sort of shepherd you through this. And they describe that as like a therapeutic alliance. And if you sort of subscribe to that alliance with your patients, you're going to get a lot more compliance. And so that's sort of, where I come from in my thought process.
I think that's a really interesting terminology used, which is therapeutic alliance, right? I know for myself, like there was a physiotherapist, Mitch. He's this gentleman who works up at Glen Eagles Physiotherapy by where I live, and he mainly focuses on IMS. And for me, that was perfect, because I have like a large background in doing my own kind of exercise, my own work. I have a history with injuries, so I was less focused on that. I was already, if anything, doing too much of that. So I needed the more actual, active physical therapy from the therapist. And as well, like I have a really good relationship with him. Like he's a really kind individual. I would talk about him. I would always check in with how I was doing. And so there was this really big component of like this therapy component of almost going in there and like feeling supported by him. So it was like beyond just getting like physical and manual therapy. It was like as a team together trying to tackle a problem. And I know for myself that was a really beneficial thing, and something that had a big impact on my life. So I just think that's a really interesting point that you're pointing out there.
Yeah. So Mitch has done a great job, whether you put a name to it or not. And, I can talk a little bit about, and Kyle, you can chime in here about our relationship since I treated Kyle. And I think for me, living that therapeutic alliance with Kyle he was honestly surprised when I said, I'll check in with you in 8 weeks. And, like I was on the dot 8 weeks later or 6 weeks later or something like that. I reached out to him immediately. I joked I had it on my calendar, but that's like, Kyle didn't need a lot from me, but that was part of the journey that we had together.
Yeah. I guess this kind of brings me to one of my questions. I think that we talked about the mental part of it. I'm interested in the education part of it. Like what percentage of people come into an injury and come into this kind of situation with a lack of body awareness, a lack of motor mechanics, a lack of understanding of even what is happening to them in the first place? And how do you, or maybe they're convinced of one thing but it's actually the other, they're misinformed. How do you guys judge that kind of understanding of someone's own body? Yeah. And like with Matt and I, like I've been a coach, I've been an athlete my entire life. I understand my body really well. And so like he said, our relationship was much more, it's just like, all right, what do I need to do? Here's my time frame. I'm going to reach back to you in 8 weeks. It's like, all right, I got it. Like I understand kind of the situation that I'm in and what I need to do. This is much less hands-on. But yeah, I think that if I were in your shoes, I think the biggest issue I would see is just kind of like trying to get that education piece across and getting people to understand mechanically what is exactly going on and how they need to connect with the injury.
Yeah, when people walk in the door, you just have no idea to start with their level of understanding of how this is going to go. Like you said, their body awareness, have they been injured before? Do they know what it's going to take, how long it's going to take, that kind of stuff. So again, that subjective exam is huge. You get an idea. And then towards the end, every single session, I try to end with a piece of education, starts with that initial evaluation. You're trying to explain to them, A, what's going on, B, how long it's going to take, or we think it's going to take. Everyone's a little different with that, and then see what to expect along the way. Know that there's going to be some flare-ups, know that it's not going to be a straight line, just kind of reassure them. And again, this comes back to people's personalities. Some people, you got to spend a lot more time, And one thing that we've gotten into as a profession, that I think is very helpful is when we start educating people. I don't know if you guys have seen these spine models before, but they're awful. They're these spine models with these giant red herniated discs on the back, right? And we used to sit there and take those things like, this is your back. See this giant red thing? It's poking out the back of your back, and it's this snake venom that's irritating your nerve and causing your leg to go numb and be on fire, and that, what does that do? That just freaks them out, right? They think I had something blow up in my back and now my leg's on fire and da. So we've really shifted that. Even if we suspect something like that's going on, we don't word it like that. We don't bring out those giant models. We know that these injuries happen. They can get better on their own with some PT. Some of them need some procedures, but we got to give it a good shot first. And I think they really like that approach. I think that helps a lot in the long term as far as, keeping them engaged and not scared.
That's super interesting. I think that that point, if like, it's almost the difference between like a person coming to a doctor and being like, "What's wrong with me?" and they're just like, "You're fucked. You've got a herniated disc, and your leg's gonna be messed up." It's like, it's just so cut and dry. And your job is almost this middleman to kind of like fluff it a little bit, and like how serious the situation is, but your job is kind of like, it's not about telling them how seriously messed up they are. It's about giving them a path forward. And sometimes ignorance is a bliss, and
Absolutely.
Sometimes it's better just to give them steps forward instead of telling them just how truly bad they really are.
Yeah, so I would say to your original question, Kyle, if someone comes in and starts to speak in sort of anatomical terms, so again, using you as an example, like you knew what your talus was, you knew what your calcaneus was, like where they're at. So if someone comes in with that level of education and they're sort of involved mentally in their recovery, it makes a little bit of a richer sort of physical therapy and rehab course. It is, as a provider, somewhat intimidating because you're like, oh no, have I studied that anatomy recently? And sometimes you haven't, and then you're just like, okay, let's hear what they have to say. And then if you start to get somebody who delves into, their own belief structure and sort of their own conclusion. That's a really hard thing to unwind as a provider. And personally, I haven't found it to be a very successful thing to do, to be like, well, you're wrong. This is me. I'm the authority. I try and sort of nibble at the edges. So just you sort of acknowledge their self education, right? You never say, "Oh, you went to Dr. Google," and like make it a joke, because it's like it's so insulting to these people who are choosing to come to you. They're spending their time and their energy and everything like that. So you try not to do that. And to sort of Kevin's point, there's like this whole class of physical therapy discipline called pain neuroeducation. Yeah, what is it? It's like basically pain science. PNE. What does that stand for, Kevin? Do you remember? I have it written down.
Pain neuroscience education.
Yeah, I think that's what it was. But so it's just like this whole group out of Australia. It's sort of his name's Larimer Mosley. If you want to look him up, he's absolutely hysterical, frankly. And David Butler, and they've sort of pioneered this whole idea about how your words matter, and then the value of those words. Evidence has indicated that a positive provider, believe it or not, has pain analgesic effects. So you can actually make a statistically significant change in people's pain perception within a session just by being optimistic. It's like just one of the crazier things that we've seen. So, we try and be optimistic. We try and avoid terms like, oh, you're broken or your back's screwed up, like you'll never be the same. Like all those things have no value, whether or not it's necessarily positive, like there's a positive prognosis. We still kind of nibble around the edges on that one. So it's pretty cool stuff, frankly, because there's good science behind it too.
That's super fascinating for sure. And obviously, like, back to, I think the whole beginning of this so far has been that underlying of the psychological aspect of the biopsychosocial model, right? And I think there's obviously like a fine line you need to toe. You need to properly educate someone, like they need to have like realistic expectations and stuff. But at the same time, there is a lot of nuance in perception. And I know, speaking for myself, just coming out of quite what I would call for myself a traumatic injury, right? There were really, really dark periods where I was in this kind of cognitive decline and, washing machine things over my head. Like I'm never going to be like able to do the things I want to do. And like, I'll insert X a million bad things. My pain's so bad, and that like drastically affected just my mentality, physically, how I felt. I was lethargic at the time and stuff. And so I generally feel like anecdotally and from my own experience, having that little bit of positivity, having that optimism in your life and in your experience. And also like you can word something to someone like, okay, you can never do X again. Like that's one way of wording it. Another way would be like, you have new limitations and you don't want to damage these limitations, but we don't actually know exactly what that line is. So let's not jump to any conclusions so far. You know what I mean? Let's work hard and let's get you in the best possible space that we can to be successful in your life and to feel good. You know what I mean? Like there's just, it's virtually the same communication. Ultimately, you're damaged and you're going to have a limitation, but one is very definite and, can be psychologically like, oh, well, to Kyle's, terminology here, I'm fucked. and the other one is like, okay, well, like, maybe I am fucked, but we don't actually know that yet. So let's find that out, like where is this actual new limit of mine?
I think right there, that's the key. I think that a great way to approach it is, yeah, you're injured and you're going to have some limitations, but go find them.
Yeah.
Go find the limitations,
right.
Find the edge of where you are now. Instead of telling you like, okay, these are your limitations. It's like, how do you know? You got to go find them. You got to spend, years trying to recover and get back to where you were, and you'll find where it stops, but it's on you to find where those edges are, not someone to tell you where they are.
Yeah, I mean, your body has a way of speaking to you in a lot of ways that we as physical therapists just interpret. And Kevin talked about these asterisks, right? We have subjective asterisks, so it's like you can't do this for this long because it hurts this amount, right? Basically, and we can just track those, and we can say, well, how does this compare to where we were first? And then we have objective asterisks that we're like, well, I can't do this, and then my shoulder range of motion is off by 15 degrees, whatever. And so we can track those, and then we can marry that together and have a great idea of whether A, this is working, and then B, what's your prognosis. And I think, if we kind of think about like muscle imbalances and all those things, like getting through all that stuff is wonderful, and it's all part of your recovery. But it does sort of start with the subjective and then sort of builds off of there.
Yeah, one of my favorite parts of the whole job is taking somebody when they're in the acute phase of an injury and just working through them week by week and slowly seeing them improve. And you can tell they just want to go, they want to go for the run or play the soccer or whatever, but you're kind of holding them back a little bit. And you're saying, I promise we're going to get there, and they're anxious and they want to get going. And eventually you're like, all right, it's time to go, and you let them go and you let them run. Let me know how it goes when you come back the next time. And they come back in the next visit and they're beaming, they did it. They feel good. They went for that 5-mile run. They didn't have any pain, it's like, but because to your point, you got to give it a shot. You can't just baby them forever. You got to be aggressive at times. And obviously that's up to your PT and doc's knowledge to know when to give them the green light. But it's the most rewarding thing in the world when they come back and they're just big old smile on their face and they're stoked to tell you how good they're doing.
We have foundational objective tests, right? So Kyle, if you want to talk a little bit, like when we first met, Kyle couldn't do a calf raise. And we know based on sort of what our testing is, like normal is 25 calf raises, single leg, right? We know that to be normal. And, if we're going to say, okay, you want to participate in sport, well, you're not normal yet. So these are the consequences. This is the recommendation, but it shouldn't prevent the patient from trying different things. And I know personally from Kyle's experience that he wasn't strong enough, but still went climbing and did fine.
I'm still struggling with the calf raises. I'm doing them on the side of the stairs, and I'm like getting strength back a little bit, but it's like getting a full body weight on one leg calf raise with full range of motion. With how damaged I was, it's really hard to get that back. And I'm seeing progressive return of strength. I definitely have a lot more strength, just like static. Like I can get myself into a flexed position and then stand on it and not have it collapse. But like getting up into a full calf raise is like nearly impossible still.
Yeah.
So it's just like, it's a big long road, but yeah, I mean, those metrics you gave me, it's really nice to set those goals and just to have those actually foundational numbers to be chasing and to measure your progress.
And I think there's a good point to be made there for the listeners and stuff. Like if you guys do find yourself in a PT clinic injured, you should definitely find some PTs and docs and providers that have a plan and they have specific return to activity or return to sport metrics, things to measure. So it's not a guessing game, right? You guys need to prove that you can do these things before we let you go loose and do them. So don't, try to avoid the practitioners that just kind of put you through the random stuff and say, oh, okay, you're good to go now. That's not going to work out well for you guys.
I think an interesting point I'd like to bring up that I think I've talked about before in previous episodes and for people who are listening is, I've called it your support group, right? And so it's kind of building a relationship with your support group because the human body, we're all taking time bombs ultimately. None of us is going to live forever. Our bodies are going to slowly deteriorate. Some people are going to do much better than others. And so do you want to try and find a support group when you're going through a traumatic injury or you're really hurt or something's going wrong? Or do you want to maybe have an approach to prevention, from being injured, and then B, if something does go wrong, actually already having that biopsychosocial relationship with somebody who can help you out through that kind of process, right? And so I kind of say this is that like it's not a bad idea to just find a therapist or find somebody, do an assessment, go get your body checked out, find what your muscle imbalances are, maybe get like a routine, check in once a year, even if you don't feel like you need it or it's not something you do. I'm a pretty big proponent of saying like I think that's a really good idea for people to do. And as we discussed earlier, people really want that that acute manipulation by somebody. Like people talk to anybody, they go for massages, they go to the spa, they do whatever. But I know really few people who are like, oh yeah, like I checked in with like a physical therapist or my physio once a year, and and we're seeing improvements, or we're not seeing bad muscle imbalances, or my body's doing well. And I just think it is an interesting relationship there that I think people could probably really benefit from doing something like that.
Max, you speak for yourself. I'm doing the Joe Rogan routine. I've got the cold plunge. I've got the sauna, the NAD, the metformin. I would live forever, man. I'm good to go. No, I'm just kidding. But it's a really good point. And that's one thing that we as a community have been pushing for is treat us like a primary care provider, that we can do these maintenance checkups, right? Like preventative checkups. An ounce of prevention is worth a pound of cure, right? Like you go to your dentist once or twice a year. Why don't you come to us once or twice a year? Some insurances will let you go straight to a PT, and so you can take advantage of that. Some insurances you need a referral, but I mean, that's what we're trained to do. We're trained to pick up on musculoskeletal impairments, and those impairments might be sub pain impairments right now, where you're walking around with these dysfunctions, but it hasn't turned into pain yet. But that next step or next climb or next twist or whatever could be the one that kind of lights you up and sets this whole thing in motion. So we can do a good job of preventing some of that stuff and identifying some of those issues to work on.
Yeah, so I think this is to me it's a great transition. I think we should talk about some of these situations that we can avoid. I think moving forward into the rest of this podcast, we're going to be talking about traumatic injuries, repetitive strain injuries. I'm curious, as before we jump into the injuries themselves, let's talk about some of these muscle imbalances and some of these motion patterns that people have, especially when it relates to climbing, that you guys have seen, that people can just fix now and avoid getting themselves into some of these injuries we're going to be talking about later.
Yeah, I mean, so I would say there's my interest is more lower extremity. So I think the one that came out most in light is a muscular imbalance between sort of quadricep strength and gluteal strength, and the impact that has in sort of closed kinetic activities. So primarily, what we see is this dynamic knee valgus moment, where essentially is when somebody plants their foot dynamically, they get inward collapse of their kneecap. So you get sort of an internal rotation of your hip. Your knee collapses towards the midline, and then it puts you in a very susceptible position for a major knee injury. Climbing, you're most likely going to see that sort of in bouldering or potentially in sport, where you fall to the ground and you need good loading mechanics, or you swing back into the wall and you need those loading mechanics. So technically, believe it or not, you're supposed to have a 1-to-1 ratio between your gluteal and quadricep strength. And Kevin, if I'm wrong on anything, tell me. But I mean, that's like obscenely strong gluteal musculature. And then specifically, we work in sort of a forward and back, or sort of sagittal plane motion, where our knee is dynamic and it works in mostly, when you're putting the forces, like when you're moving dynamically, it's transverse or rotational. So we train a lot, up and down. We don't train a lot in any kind of torsional motion. And so you see this massive imbalance in your glute medius, where there's high level athletes, professional athletes, even in dynamic sports, that have what would be, subpar glute medius strength. And particularly women athletes, soccer players, they sustain like a traumatic knee injury, 25% greater because of this sort of muscular imbalance. So, the one person I would probably recommend a lot of like sort of self-motivated people to look up is Chris Powers. And if you follow sort of a Chris Powers glute medius strengthening program, I'm sure there's a ton of stuff on like YouTube or any of the social medias, but he does a wonderful job correcting the dynamic knee valgus. And that would be sort of where I'd start from a lower extremity standpoint. That has been probably one of the most powerful exercise sort of routines. And the best exercise I could give is a standing clamshell or fire hydrant. If you can do one of those, your lower extremity mechanics are really, really good.
Yeah, this particular topic is something of extreme interest to me. I've always the less scientific terminology that I refer to this particular situation is just being quad dominant.
Yeah.
I feel like a lot of people are quad dominant, and I encourage our listeners and to go around and look for what Matt's talking about. Go look around. Unfortunately, it's super prevalent in women.
Yeah.
But look for that knee concave, that almost that like triangular leg position that's inward. Knees touching on the insides. They're like, you put the foot down, the knee collapses inward.
Yeah.
Someone doing a squat and their knees are inward. And it's just like, it's horrific. I see it everywhere.
Yeah.
And it's like, some people are so bad, I want to come up to them and just give them a quick like awareness.
Give him my business card. Is what you should do.
Yeah, exactly. I'm like, you're squatting 200 pounds and it's all on that one quad muscle right above your knee. And I'm just like, this is really scary to watch. And so to me, like this is such a huge topic. It's really important to train that posterior chain. You gotta use your glutes, gotta use the hamstrings, gotta use the lower back. And it's just super, super important for climbing, because what are you supposed to do on overhanging stuff? You got to keep your hips close to the wall.
Yeah.
That's all posterior chain. And so it's just like really, really important for people to pay attention to this. So
no. Yeah. I mean, so another visual cue for somebody who's looking at themselves and doesn't know what this means. If you're standing and your kneecaps are looking back at you, and then you squat and your kneecaps are cross-eyed, you got some problems. You need to see somebody quickly, because you are a time bomb. And women, for a variety of reasons that we don't necessarily have to go into, but if they, they're way more susceptible than men. And I think for me, that's been like probably the most prominent movement dysfunction for the lower extremity.
So if we were talking about this kind of like, antagonist, agonist kind of muscle, posterior chain, what is the general approach you're going to take to somebody? So like, you're going to give them their physical assessment, maybe take them through some range of motion. And then like, what are you building into? Is the ultimate goal to get them into actually being able to properly load the muscle to strengthen it? Maybe just like take us through what somebody could do through that process a little bit.
Yeah, it's kind of funny. You go through PT school and you're like, okay, you got to memorize all these things, right? The shoulder should abduct 175 to 185 degrees. The strength ratio should be this and that. You can pretty much take that and throw it out the window, because for me, at least, what I really strive for is symmetry. If it's a right shoulder issue, I want to see the left shoulder move, the right shoulder move just as much and as smoothly and in the same sequence as the healthy shoulder, and the strength should be the same as the healthy shoulder. So something with imbalances, I'm not comparing you to what it says in the literature. I'm comparing you to what it is on the other side, and that's been a valuable lesson learned early in my career.
And then, so as far as like, if you are looking at the other side, and let's say the other side was much more dominant, what's your approach? Like, are you starting out with isometric exercises, so like body weight, range of motion, and then are you eventually getting into loading depending on what the muscle is?
So I think of it this way. This is an old like theory, but his name's Syriac. He's like this, like it's old. But essentially what he talks about is pain and muscle contraction. So you talk about sprains or strains or anything like that. So the first thing is like, if there's in the acute phase, we want to load that muscle in a pain-free manner. So typically what that means to me is we start off with isometrics or some level of position where it doesn't provoke their acute pain symptoms. And then from there, you can go into concentrics. But I have a bias towards more function, because ultimately that's where we want to go as physical therapists, is a return to function. Doing, like Kevin said, like some of these tests, they're just fancy stuff for us to do, but they don't have functional value. So I'll go into loading in a functional way, and mostly being sort of pain driven. So if it doesn't hurt, then we can push it. We can put it into more provocative positions and sort of load from there. But typically it goes isometric to concentric, and then the ultimate goal is that eccentric loading, because we know the eccentric loading is actually what remodels tissues. And, that's where you're going to develop sort of more of that symmetry that Kevin eloquently described.
And to kind of dovetail off that too, I mean, those are all good points. And I think in addition to that, something that I've kind of used in my arsenal is putting, especially if it's a muscle or tendinous issue, like first off, paying attention to how irritable it is. If it's extremely irritable, we're doing pain modalities. We're trying to get that thing calmed down. That's the place where you want to do maybe a little ice, maybe a short course of NSAIDs, something to just get it to where it can tolerate something, right? And then with the isometrics, like Matthew was talking about, putting the tissue in a shortened position, right? That's going to be a lot more tolerated for these people than a mid-range or a lengthened position. So for example, if we're thinking like climbers get a lot of like tennis elbow, right? Because they're gripping all day, which is the front of their forearm, their flexors, but the extensors on the back of their forearm aren't pulling their weight. So they get these outside of the elbow pain, this lateral epicondyalgia is the name they're using now. And you might find someone that's just super hot, right? They're outside of their elbow. You can't even touch it without them yelling at you, right? It's incredibly painful. Once you get that pain down, I'm propping that wrist up, right? Like I'm putting that wrist in kind of a position in extension. That's going to shorten all of those tissues, put them in a little bit of a protected position, and start my isometrics there. And that might be all we do, right? I mean, load essentially is king. Like that's at the end of the day, if you're treating a muscle or a tendon, you need to load the tissue. And that might be all the load that it tolerates. And then the next day, I'm putting them in more of a mid-range where your wrist is just neutral, right? See how they tolerate that. And the next time they come in, if they're tolerating stuff, I'm putting them in some flex position where I'm actually putting that muscle on tension and then asking it to contract. If they're tolerating that, then we're moving into the isotonics where they're actually lifting weights up and down, up and down, up and down. And then it just goes from there, right? And then we're cranking on it. We're making them work super, super hard. And eventually, it takes some time, especially with tendon issues. But that load is what's going to stimulate the healing.
So in that case specifically, like in the tendon and this like overuse kind of situation we're talking about, can you run through, because I'm curious, what is actually causing the discomfort? What's causing the pain? Like anatomically, what is causing that pain?
Great question. Yeah. So I mean, you can think of those tendon issues as either a tendinitis or tendinosis. Right, tendinitis everyone's heard before. Maybe not everyone's heard tendinosis, but in acute injuries, you're dealing with a tendinitis. Itis means inflammation, right? So that's the example I was talking about at the beginning, where it's just so hot you can't touch it, right? You gotta calm it down, right? So the pain generator there is probably some micro tearing in the tendon. The inflammation itself is causing pain, right? The chemical pain from the inflammation. Whereas the tendinosis is more of a chronic issue. You got these people with chronic Achilles tendonitis or tendinosis, patellar tendinosis, this lateral elbow issue. And what's happening there is that initial injury or that just slow development of injury is actually tearing some of that collagen tissue, right? So you can think of these millions of collagen fibers, a percentage of those are getting torn, which hurts, right? And then your body is not healing it properly. Like the collagen is not naturally just laying back down in the same parallel, nice, long, strong pattern. It's getting laid down in this like really unorganized, kind of haphazard pattern. And that alone is painful. Like that tissue is not functional, right? It's innervated with nerves. It hurts. We've got to stimulate through load some proper healing in that tissue. In addition to that, a lot of this chronic tendon stuff, they get little blood vessels that infiltrate the poorly healing tendon. And you think blood vessels, great. I mean, that's going to supply blood, but it actually doesn't. In this case, the blood vessels are on the periphery. They don't get down into the actual tendon. But they can contribute some pain as well. So that's kind of the pathophysiology of that issue.
So when you're talking about getting it under load to heal it, could you explain a little bit more about like what about getting it under load is actually promoting the healing process?
Yeah. So when you are loading, so tendons, muscles attach tendons to bone. So the muscle transitions to the tendon and attaches to the bone. By contracting the muscle and applying this tension load through the muscle tendinous junction and the tendon itself, you're stimulating fibroblasts, which are these little cells, to lay down new collagen tissue, essentially. And this new collagen tissue should be in line with the proper line of force, and it's going to slowly overtake some of that crappy tissue that was being laid down earlier in the process. And that essentially is going to improve the tensile strength of that tendon and improve your pain.
I think that's really important. And the thing is that it might seem counterintuitive to some people who don't like think about like loading things a lot. And sometimes there's an interesting line to teeter on of like, okay, I need to listen to my body. But when you understand the physiology and, you know, the we could say the biochemistry, and you know enough about your body and the circumstance, then you are able to actually know when to push and when not to push, right? And so there's times with my own injury where, okay, I might not feel really good. And some of those times are legitimate times where you're like, you need to have this intuition or have a professional who can let you know, like, this is not the time to push. Like, this is literally something is wrong. You know what I mean? And then there are other times where it's like, okay, I feel bad. I feel sedentary. I feel tired. Something's a little sore, but like, it's not actually injured. It's not over inflamed. It's not giving you that bad feedback. And when you do go, you exercise it, you load it, you push it, you stress it, you pump blood and fluid and lymph in there, and, you know, all these things, it actually is contributing to the healing. So I just think for some people listening, that might seem counterintuitive that like, oh wait, but it's hurt. Don't I need to leave it alone? It's like,
right.
There's
a great point.
There's an interesting nuance there, right? That like maybe depending on how acute and how inflamed it is, but generally like active recovery is always, at least in my opinion, I don't want to put words in your guys' mouth. It's, you know more about this than I do, but active recovery to me is always a better way, and usually supports your body and your health more, right? So.
Yeah, Max, I have like some real simple parameters that I give most of my patients, especially if they're tentative about doing these things. And so we have the numerical pain rating scale, right, which is sort of generic and people somewhat disregard. It's actually a very powerful sort of self-detective tool. And what it allows us is this: is like my 2 is different than your 2. You know, Kevin's 5 is different than my 5. But between myself, I always know what my 2 is, right? And so I tell people this, right? 0 to 3 is mild, you know, 4 to 6 is moderate, 7 and above is severe, right? But here's the kicker, right? Even in severe pain states, it doesn't necessarily mean it's like nociceptive, which is like pain with damage, right? It could be some kind of like pain signal that goes beyond your tissue changing. And so, frankly, I tell people we can load you very comfortably if our baseline pain level is whatever it is. During the activity, we can raise that by 1 point, right? If we go 2 points and above, now we're getting into somewhat of a danger zone where we could be causing damage, right? But if we do 1 point, and then when we stop the exercise and the symptoms go back down to your baseline in less than an hour, we're all right, right? That's an okay loading session. And then, you know, so you have that during, right? So it can't go above 2. You have an hour later time frame where it should go back to baseline. And then I tell them the next day, your pain level should not cause functional loss. And what that means is if we go and we have a new knee or something like that, and we say, okay, we've done a lot today. You know, this morning, what was it like rising out of your car? And then the next, we do a treatment, you do your exercises, blah, 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 all those parameters within session. They're fine. The next day, it's hard for you to get out of your car. Then we have to reevaluate our loading principles. And the nice thing is you can be that detective. You don't need me there to tell you, oh, it's a 2 today. You know, is it a 2 now in an hour? Or the next day, is it harder to do something that was easier before the treatment? And I found that to be a very successful way to push people, and they can do it themselves. And they can report that back to me in like 3 simple questions. And then we know what we did was okay.
I'd like to challenge that a little bit, if you don't mind.
No, go for it.
Yeah. So I guess mostly the rule that you have in state where if the pain goes up the next day, you said by 1, right? That was the metric, 1 point the next day.
So it's basically doing the activity is 1 point. You shouldn't go above 2 points. But then if you recover in less than an hour,
the next day, what about like, so,
yeah, so that's,
you're saying loss of mobility, loss of function?
It's more a functional loss, and it's an imperfect thing, but yeah.
That's fine. Yeah. I guess I challenge it just because like in hypertrophy workouts, sometimes I'll wake up the next day and I can't even reach behind my head,
right.
You know, like,
right.
And so, and for instance, I just went for a run yesterday. Sure. I ran a mile and today I'm limping around. Sure. Like I definitely lost function.
Sure.
But correct me if I'm wrong, this is my own personal journey here,
Right.
but I feel like without those moments where I'm pushing the envelope and I am kind of in pain the next day, I won't progress. I feel like in my understanding, that rule where like, okay, yeah, I can't do anything where I'm going to be limping the next day, I feel like
Right.
it's going to slow down my process a lot. Like, do you have any kind of notes on that and how strict this rule actually is?
Right. So that's a great discussion. And so the one thing that I would like to emphasize is there's a difference between a pathological state and then a training state. And, it's not a steadfast rule. So you have self beliefs that will outweigh any opinion that I give you, right? But if you're in a pathological active tendonitis state or recovery state, and you do that, you could be setting back your recovery. For instance, in a bone, you could cause a malunion, you could cause, a serious issue. In a tendonitis episode, you could continue to cause an uncontrolled inflammatory state that we misinterpret as sort of this, oh, okay, this is just normal because of the loading process. So there's a lot of nuance to it. And you're right, you should push back on it because your self belief and your background dictate that you need to push yourself. And as your therapist, I would just say, and being your therapist at times, I would say that's okay. And we'll have to restructure what our thought process is in order to best get you to where you need to be. And Kevin is going to know quite a bit more in regards to performance and return to performance in those situations. But I would say that would be a great conversation, and it would be probably, as a provider, incorrect for me to be like, well, you got to stick with these roles. I would say, okay, let's see where we are. We can do some objective tests, and then give it some more time.
I think there's also
And
I think that you're.
Sorry, you want to go?
Just
You want to
three
go?
of us at once.
You
That's
go.
fine.
You go, Kyle.
This is a meaty topic. It's a meaty
Yeah, I
topic.
guess so.
Okay. Yeah, mine's gonna be really quick. I think that you brought up a good point. I think that the rules that you outlined there are really applicable to the beginning stages of a traumatic injury or the beginning
Correct.
stages of a chronic injury, something where it's very severe and you are at risk of malunion, you are at risk of rupturing a tendon. That is where you do have to play the line really safe and you do have to be cautious about how much load you're putting on this particular injury. But my example, I'm 10 months after injury, my bone is fused, my tendons aren't going to be rupturing. And so I'm not running that risk. I don't have that risk. And so I can push those boundaries a little bit more. And it sounds like that's kind of where we're switching to, is that getting back to performance versus recovering from an immediate acute injury.
I think an important distinction as well along those lines is differentiating between delayed onset muscle soreness and normal training adaptation and, your pathology, right? They're two different things. Like, so for your example, if you went and ran and you're like, God, I ran and my calves are just sore as hell. I can barely get on stairs. My quads are on fire still, but my ankle's fine. My ankle is not swollen. It's not extra stiff and sore. It's not pinching. I'm perfectly fine with that, right? That's all good. But if you come back to me and you say, yeah, my ankle's sore, it's stiff, I can't move it, it's blown up, then okay, you did too much, right? We got to back down a little bit. If it's more than that 1 out of 10, like I was talking about. So I think what I usually ask people, people come in all the time and they're like, oh man, that last workout killed me. And I was like, well, what do you mean? It's like, well, I'm sore here, and they point to their outside of their hip, and they're a knee patient. They're in for like a patellofemoral issue or something like that. I'm like, awesome.
You're like,
let's do it, right? Like, that's perfect. That's exactly what we want. That's and then it comes back to the education piece. Like, well, this is what we got to do. This is how muscles get stronger, and this is why you're sore, and it might get sore tomorrow even more, right? But how's your knee doing? Oh, my knee's actually fine. Okay, well then we're right on track. So it takes a little digging sometimes to really differentiate between pathology and workout soreness, muscle soreness, things like that.
I think it's like, as well, it's a spectrum, right? And so someone who maybe is way more in tune with their body, they're way healthier, they have a way larger background in exercise, they might respond to this a little bit better. They might heal faster. They might be able to like teeter the line a little bit more. And that's where, to me, I think of it as a spectrum. But I think going back to that functional loss, a coach that like I idealize, this guy, Scott Johnston, he has a good description I think he has of it based on functional loss. Is essentially like, so if you have like a repetitive strain, like a tendonitis or plantar fasciitis or something like that, right? you wake up in the morning and you're like, oh, it's really hurting. It doesn't feel good. And then all of a sudden you're pumping blood into it and stuff. And like in the middle of the day, you're good. And you go do your workout, right? So it's back to that, okay, you got yourself in a state where you felt okay. But like ultimately the way you woke up was actually a much better sign of how your body was doing than once you stimulated an area and pumped blood and stuff like that into it. Because ultimately I think it was back what Matt was saying, where overall, like you might be able to do some of that, but there's probably a pretty good chance that you're going to be slowing your healing time or elongating the damage that you have. And obviously there's caveats to this with everybody. And then as well, I think from your guys' perspective, you guys have to go off of averages, right? There has to be some kind of standard that you can adhere to. And so as a generalization, when you're talking to most people, I would think that, for the majority of people, if you have distinguished between, like DOMS, delayed onset muscle soreness, and you do have that, functional loss, it's probably pretty safe for a lot of people to be like, back to Scott Johnson, actually, a good saying he has is like, it's generally better to be undertrained than overtrained. Undertrained, you can like, and this is more pertaining to racing and stuff, but you can dig deep and you can pull a little bit more out of the gas tank and use willpower. But once you're overtrained or you're hurt or you're damaged, like you're kind of hooped until you take a break and things heal, right? So it's a distinction there. I just think interesting from my perspective.
Yeah, and what I would say, Kyle, is this: is like if you find a provider and you challenge that provider in a way, and they sort of scoff and back away, or like say, "Hey, that's not what I know or believe," you're probably at the wrong provider. So, I would say we got to give space to our patients to express their self-beliefs, because that's a really sort of powerful thing when you can connect and get the patients and your belief structures together. And like you need that symmetry in order to have like a good rehabilitative course.
Yeah. And I think there's a line between like pushing yourself and being dangerous. I think that as a PT, you could just, you would understand the limit, that line of where it's like, all right, like, you're doing this. I'm going to warn you that you might screw yourself up pretty bad. Like, here's my warning. And I think that really goes back to the beginning stages of the injury. It's like really important not to push it too far. Because you can, like you said, like the bone not coming together and rupturing tendons, like those are real risks.
And I think it's important too to like, if you get a patient in front of you who's going to push too hard, and that's their personality and they want to go for it, is to channel their energy into something else, like runners. Let's go hit the spin bike, man. Go crazy on the spin bike. You can do that for hours if you want, because it's not weight bearing on your heel or, whatever. And just finding activities and whether it's weightlifting or biking or swimming or whatever, and find activities where your PT or your doc gives you the full green light, and just go crazy with that. Just to get some of the competitive juices out too, get some of the endorphins running and all that stuff. So good for you.
Nice. Seems like we basically covered the topic of repetitive strain injuries. Do you guys? Oh, actually, I have one more. We kind of chatted about this in our pre-call. It's the hunch, the overactive back overgrowth, and the lack of pushing muscles.
Yeah.
The climber's back, the climber's hump.
Yeah.
Can you guys kind of talk about the anatomic causes of that and the risks people run and the injuries you've kind of seen from this stereotypical climber's back that we see all the hard climbers have in the gym?
Yeah, absolutely. So what Kyle's talking about, I'm sure, if you got a listening group that are full of climbers, they all know what we're talking about. But people that have, this mid back that's excessively forward bent, they're kind of hunched forward, their shoulders are rounded forward, their palms are facing backwards, their head's kind of protruding forward. We all know what the picture I'm painting here. And what happens is, when you're climbing, it's such a flexion dominated sport, meaning that you're hanging onto a wall, right? So your arms are pulling down, your legs are pulling up, your core is pulling you forward, like you're almost doing a crunch, right? And all those forces are contributing to that posture. There's so much pulling with your arms, it's such a lat dominant sport, and those lats are internal rotators of your arms. So that's why their palms end up facing backwards and their shoulders are rounded forward. It takes their whole arm and just rotates it internally. And this can lead to just a whole host of issues, and this is a posture you see in climbers. You also see in people that sit all day, right? They sit in their computer and they hunch forward, or they text all their students, things like that. Starting from the top down, their head is so far forward, right? They say that your head weighs 12 pounds when it's straight up on top of your shoulders. When it moves forward 2 inches, it's now 16 pounds. When it moves forward 2 more inches, it's now like 30 pounds, right? And that's so that your neck joints, your muscles, everything's got to support so much more weight. So you can imagine, everyone's sitting up tall right now as I talk about this. But you can imagine how overworked and how bad that is for your neck, right? And then you move down to the shoulders, and you take this glenohumeral joint that's just inherently unstable. It's the most mobile joint in the entire body, so therefore it's the least stable joint in the whole body. It's a ball and socket joint, but it's really, people think ball and socket. This socket's just encapsulating the whole ball, and the ratio between the ball and socket is equivalent to a golf ball sitting on a tee, right? So it's just so exactly. So that's how small your socket is. You have a labrum around that as well, which is not a bone, it's a soft tissue that kind of helps encapsulate the head of the humerus, but that is not bulletproof tissue, right? You can tear labrums, you can rip labrums and all that kind of stuff. So because it's such an unstable joint, and you take it and you put it in a bad position by having tight lats that are pulling internal rotation, and you add on thousands of reps of overhead activity, you're going to irritate some stuff, eventually, potentially tear some stuff. Right. So that's one of the first things we look at in shoulder patients is what is their posture? Like forward head, rounded shoulders, palms facing back. We're starting there, right? We got to fix that. Obviously mid back issues just from being forward bent, and then the whole spine's one unit, right? So if the mid back is way forward bent, something's got to make up for it. So a lot of times their low back becomes excessively backward bent, right? We all naturally have some backward bending in our lumbar spines and our low backs, but we get a totally excessive lordosis, excessive backward bend, which then puts pressure on some of the elements in our lumbar spine. It can create low back issues. So as you can tell, just posture alone can cause a whole host of problems that is important to keep in mind when you're working on your mobility.
Yeah, to follow Kevin's point up too, is we want to think of your shoulder blade and your shoulder as one complex. So a lot of people think, shoulder pathology is associated with the ball and the socket, but it's actually a little bit more dynamic than that. The relationship between how your shoulder blade moves, because that's what moves the socket, and the ball in space is vital too. So when you have this sort of adaptive changes where you get this sort of curvature of your shoulder blade forward, what you're actually doing, and you can do this as an experiment, like you're actually reducing your capacity to get overhead, frankly. And so when we think about range of motion, overhead range of motion, 180 degrees, 120 of that comes from the ball in the socket. The remaining 60 is how your shoulder blade moves relative to your sort of rib cage. And so that sort of, it's like sort of scapular-thoracic motion is vital. And if you're in a sort of, that climber's position reaching overhead, you're losing, a third of your motion potentially, and relying much more on your glenohumeral joint than your overall shoulder complex. So, there's some force coupling issues that we see quite a bit, lower trapezius, mid trapezius. Those things are grossly undertrained relative to like anterior deltoid, biceps, the things that make up that overall glenohumeral complex. So if you don't address those muscular imbalances, you're going to be ripe for, any kind of glenohumeral pathology. Kevin talks about a slap lesion, which is, your labrum tears. You're also going to see impingement style things for overhead athletes. That's quite common, which are rotator cuff tendinitises, things along that lines that are just as debilitating. And then, if you're reaching for an overhead move or anything like that repetitively over many pitches, like you're just not going to be as successful, and your performance will suffer, and you'll be unsure why, since, a lot of people who are in the climbing community are really fit, but they definitely have some significant sort of biomechanical faults that, tend to put them in a position for repetitive strain injuries or any general injuries.
So what are some basic exercises, simple basic exercises somebody can do to fix this kind of, pronation essentially?
Mm-hmm. Kevin, I'm going to defer to Kevin here. He's like a goddamn textbook. I'm really like going back here. I'm really enjoying this, probably more so than you guys. So let me turn this over to the sports therapist. This is like good stuff.
I'm blushing. Good thing it's a podcast because I'm blushing. No, I mean, my first go-to is to get their mid-back to start extending, right? Like the extension is going backwards, right? Like think about pushing your shoulders back compared to your hips. That's extension. And the trick is to extend your mid-back without extending your low back, right? Like we talked about, if you have an excessively forward bent mid-back, your low back's already in a lot of extension. So in other words, to long story short, to get your mid-back extending, one of my first go-tos is take a foam roller, put it perpendicularly across your spine, kind of the level of the shoulder blades, and you're laying on your back, your butt's on the ground, your knees are bent, your feet are flat on the table, right? Just kind of paint the picture here. Hands up behind your head, and you kind of arch your back over that thing. Right?
Yeah.
It's like when you used to be in elementary school and you lean back over your chair and you get your back to pop, right? Like that same kind of move is just I give that to probably 80% of my people, right? That's a good way to go. Like the thoracic spine needs to extend. It also needs to rotate, right? So another thing I'll go to after the foam rolling is putting someone in quadruped, all fours, and have them sit all the way back on their heels. So their butt's on the heels, put one forearm flat on the table in front of them, almost like in child's pose, right? Put the other hand up kind of behind their low back, and then whatever hand's up behind their low back, they're rotating that shoulder towards the ceiling.
Yeah.
Right. That's going to get a little extension, a little back bending in their thoracic spine. Is also going to rotate their thoracic spine, right? And there's like a whole library of thoracic mobility drills that you could Google, you could YouTube. There's going to be a ton more you can do. But I think an important thing for climbers, especially, is you got to hit extension, but you also have to hit rotation, right? Because you guys are turning and reaching, and if you can extend but you can't rotate, you're missing part of the puzzle there. So finding some drills that rotate as well as extend, I think, is going to be important.
From a strengthening standpoint, I like to use the exercise ball, and we'll basically put the exercise ball. So have the patient lie on it, basically chest on the ball. The ball would roll basically to your sternum, and then you can do a little bit of thoracic extension. So you want to get into sort of a plank position on the ball. You can extend a little bit into the thoracic extension, and then it's just working the scapular muscles. So basically they call them ITs and Ys, and sort of working my way through that motion. From a neuroplasticity standpoint, it's not necessarily that they're weak, but they may not activate it appropriately. So my prescriptions are typically like 4 sets for 1 minute, and that's what we've shown to be able to reconnect that muscular neural sort of unit and build that strength and foundational endurance. So that the rotation and the stretching, and then layer in some of the strengthening.
Yeah, you always want to follow up any kind of passive stretches with active stuff like Matthew's talking about.
It seems like a lot of the fixes to these problems are focused around the reconditioning of these overused muscles to kind of get them in a more proper alignment. My personal understanding for this is more of like a lack of use of the pushing muscles. So it's the anterior delt, chest, the upper chest, and the triceps. How much of that do you find, like, if someone were to start working those muscles, like, because to me, like, these people have big backs, they're strong, they have very muscular backs, but it almost seems like because their chest is so small and their anterior delts are so small that it's like growing forward and there's no balance in the front to keep it aligned. It's almost like a lack of material in the front part of the body. Does that hold true to any sort of science, or and would focusing on more pushing movements help rebalance their movement patterns and their actual anatomy?
That's a good question, and I would hesitate a little bit to give people that are already in this internally rotated forward head posture a lot of pushing activities right off the bat. Because when your shoulders are internally rotated and rounded forward like that, your pecs are going to be short already, right? They might not be strong in these cases like you're talking about, but they're going to be short. And so I think the first step is fixing the posture, right? Getting people up in nice tall posture, working on external rotators, like your posterior rotator cuff, instead of your internal rotators, such as your lats and your pecs. Once you get that fixed, then I think approaching more of a pushing program it would be fine, right? It would be totally fine. It might not be, you know, the number one thing climbers need to do to get better at climbing and to get stronger and more functional. But as far as having some balance just through normal, typical life, yes. But I think the key there, though, is fixing the posture first before you start cranking on the pushing muscles.
Yeah, and I tell people this a lot of times. You don't get injured because the muscle that hurts is the weak part of your chain, right? Like because I have a shoulder issue, or some kind of tendonitis or musculoskeletal issue, in your wrist or something like that. Like that's more because you rely on it much more than that's a faulty tissue. Does that make sense? Especially in a repetitive sort of condition. So when we have that, and we talked a little bit about like being a hot situation or an acute situation, right? Like we can't do much with that tendon, but we can work everything around it. And that's where, if we can work the muscles around it, we can actually unload that specific pathology in a way that you can still function. And then ultimately, that's what prevents reoccurrence. So if we just address the acute issue and acute pathology without looking at like the overall scope, and you can make an argument from a standpoint of, okay, hey, you want to do opposite and agnostic muscle or antagonistic muscles, excuse me. And the value of that, you can make an argument of that. From a physical therapy standpoint, is that something that we necessarily focus on? Probably not from a strengthening standpoint, but more from a sort of anatomical standpoint, like restoring normal length of some tissues that we know are adaptively shortened. Certainly, but you still have to work around the issue to look at why you're susceptible to a repetitive injury. Does that make sense?
Yeah, and I think that the point that Kevin brought up that really hit home for me and on why this my particular analysis is incorrect is because the chest muscle is short. That's like it's short. It's in a shorter position, and so strengthening it is going to make it contract more. You haven't given it the length and the proper positioning to activate properly, and so that right there makes a lot of sense to me in terms of correcting the posture, correcting the layout of the back before you start strengthening the front, because you're just going to cause it to shrink more if you're trying to strengthen a shortened muscle.
But then you also have to consider like concentric versus eccentric. So if you say, okay, I want to strengthen my chest muscles, am I going to do push-ups, a lot of push-ups? No, because that would be a concentric, adaptively short of exercise. But you could do an eccentric potentially push-up, which would then restore more sort of normalcy in the length of that actual muscle. And that has great value, right? And so that's something that you have to differentiate then too between, and it just, again, it adds this richness to potentially your recovery or, injury prevention before you even get injured.
And that's to kind of dovetail off that. Something interesting that I've learned recently is, we take tight muscles, short muscles like the pec, for example, in this situation, and we stretch them, right? And that's going to cause this muscle to slowly start elongating. These muscle fibers are getting longer and longer and longer, and eventually getting good posture. And that's all good. I mean, that's well proven over time in research that works. But when you're stretching muscles, you actually get like a transient decrease in strength in muscles, right? So just for a short amount of time, they're weaker and they're actually more susceptible to injury. If you, for example, go to a big pec stretch on a foam roller, then you go rip your PR bench press, you're at an increased risk of injury that thing. So one thing that I've learned is that if you stretch, like Matthew was talking about, eccentrically, right? So eccentrically is you're contracting the muscle, but you're contracting it while it's lengthening. So think of like the lowering portion of your bicep curl, or you're doing a calf raise, it's the lowering portion of your calf raise. You can actually get the length changes that you want with a stretch while also strengthening the muscle at the same time by doing just eccentrics, right? So, for a push-up example, right? Get up on in a push-up position with your hands on two small boxes and get all the way up there and slowly lower yourself all the way down where you're feeling a pretty big stretch in the front of your chest. And then your chest hits the ground, your hands are off the box. You kind of roll onto your back and sit back up and get back up and do it again, right? You're kind of avoiding the actual push back up part of it, if that makes sense. You can get the benefit of the stretch plus the strengthening.
A loading variation of that, I think, is if you get if you were doing a bench press and you get somebody to spot you, so you only do the eccentric and the concentric portion, the spotter just pulls the weight up and then you just get the load to stretch down again. So,
Thanks, Max.
Yeah.
That's a much better.
Just avoiding the like rolling of the push-up on the back and stuff.
Yes. I was kind of scrambling there for a second on what I was going to come up with. As an example. That's much better.
Yeah. I think they call that a negative, right?
Yeah.
In the weightlifting world, like a negative.
A negative, yeah. Mm-hmm. The last repetitive strain injury that I think I have to cover is the infamous psoas and the front of the hip, and also the point of how pain can manifest itself in an area in the body that is not actually the source of the problem. And I think that the psoas does this very sneakily, where a lot of people complain about lower back pain and really tight back pain, and they get this posture like this, where like the booty sticks out and their back is super tight and their abs are distended. And that's all, related to a tight psoas and people sitting in chairs all the time. And you also get this in climbing because you're always lifting your knees up, you're lifting your legs up high, and that's all activating this psoas area. So if you guys want to kind of talk a little bit about this particular repetitive strain kind of situation and that topic.
Yeah. So as a quick review, the psoas is hip flexor muscle. It comes off your lumbar spine, every segment of your lumbar spine, and it runs straight down and attaches to the very front of your femur, up by the hip joint, right? So it's the most powerful hip flexor you have. It's a notorious muscle because it attaches to the lumbar spine, and if it's tight, it pulls on the lumbar spine. It can create lumbar spine issues. So that actually, to answer your second question, is a good example of, well, my back hurts when I do X, Y, Z. We do a full back exam. Your back looks pretty dang good. Your psoas is what's tight, and it's pulling on your lumbar spine and creating these issues, right? So that's an example of where the issue is somewhere, the pain is showing up somewhere else, right? But in climbers, you guys are such, like, you have to get your hips way up into a huge flex position where your knees are up towards your chest, and especially kind of externally rotated out to the side to be flush up against the wall. That is a ton of hip flexor and psoas activity. So it can manifest like it can pull on your lumbar spine and create lumbar spine issues. It can create kind of front of the hip kind of pinchy type issues where you're kind of impinging your hip joint as well. So it is it takes a good thorough examination to know, is that psoas tight and creating these issues, or is it not doing its job is it not strong enough, essentially? Is it not doing its job as a stabilizer to the front of the hip and creating other issues? And that's something that you probably are going to need to go see a PT or a doc to really help kind of figure out that specific differentiation of, is it tight or is it just a weak? But I would say definitely a muscle that is involved in a lot of hip and low back issues.
Do you have any recommendations for the release of a psoas? Out of curiosity, because like I know I've released my psoas. I've also had like a massage therapist I know who's done it too. But like it can be really tricky.
Lovely,
people
isn't
don't
it?
know.
Yeah. I mean, I think so. Just go kind of circle back. The idea of referred pain is always a very challenging thing to sort of kind of work your way through. And it can be complicated in your recovery. So again, we go back and describe these hypotheses. And with referred pain, you're going to have a number of hypotheses that you're going to have to test and kind of work your way through. And this is where a differential diagnosis from a musculoskeletal standpoint, see a physical therapist, right? Like research indicates we are one of the top professions along with orthopedic surgeons. And we outpace any type of primary care provider, in regards to accurate diagnosis. So we're on par as a profession with orthopedic surgeons, and those two disciplines alone outpace anybody else. So if you go to your primary care and they diagnose you with this, frankly, it's just a guess, and that's not really going to be very specific. So if you take that diagnosis and you go and try and self-treat, the likelihood of you being successful is pretty low, frankly. Now, back to sort of releasing the iliopsoas muscle. I mean, the best thing to look up is probably the Thomas stretch, but there's some nuance with that I found because you can cheat. And based on sort of the anatomical positioning of the psoas, like if you think, I'm releasing the psoas, you may actually just be extending your back, or doing something different. So, I try to do that in session, and then try and teach them that sort of that Thomas stretch. But I don't know, Kevin, if you have any better ideas.
One that I've given to some people that I definitely go over in the clinic multiple times to make sure they're comfortable with it and they know what they're doing, because it can be a little sketchy at times, is taking like a kettlebell, like pretty heavy kettlebell, maybe 20, 30 pounds, turning it upside down so the handle is about halfway between that bone on the front of your hip, it's called your ASIS, right? That little, like, if you kind of feel the front of your hips, you have one on either side, right? Halfway between that and your belly button, your psoas lives way down deep underneath all your guts in that position, in that spot. So you take the handle of a kettlebell and set it right on top of that and let it kind of sink in slowly. And it doesn't feel good, but if you get right on top of it, they'll know, because it feels like a massage that's getting in and digging on a really tight muscle. You can also take that leg and just lift your foot up off the ground a tiny bit, and you should see that kettlebell kind of bounce up a little bit because you've just contracted that psoas muscle, and you should see that kettlebell move, right? That's how you can kind of confirm that you're on it, right? The reason I'm a little hesitant with people is that if you're too far medially towards the belly button, you can be on your bladder, you can be on your femoral nerve, your femoral artery and stuff. So not that, unless you have a super full bladder, you might rupture your bladder, but other than that, you might just irritate a nerve, or, nothing super nasty, but I would just go pee before you do it, I guess, is what I'm trying to say.
Yeah.
Have you guys heard of the Wright?
Yes, I have. That thing looks vicious.
Looks cool, man.
Truth.
Yeah.
Have you guys used it?
I haven't used it. I think Joe Rogan has toted something similar to that before.
Yeah,
it's like that two-pronged, it's like a two-pronged thing that you can sit on, thing. Right? And it digs right into your psoas. I've heard other people.
I think you lay on your stomach, and it's like this big old hook looking thing that you lay on your stomach, and you kind of sit at center right where I was talking about, and you just use your body weight to kind of sink down into it.
Yeah.
So same idea, just different position.
Yeah, totally.
Nice. Max, anything else, or you guys anything else for repetitive strain injuries before we move on to covering traumatic climbing injuries?
One thing I would, this isn't quite like repetitive injury or anything, but maybe just quickly touching on the basis of properly warming up. Like we expressed that if you were doing like really heavy loading, you might not want to stretch your muscle beforehand because you're actually elongating and increasing that range of motion. And that's a very specific thing. My understanding, which could be wrong, but I think this works for me, is that, generally you want to get your heart rate progressively up. You want to pump synovial fluids in your joints, and whatever the area that you're going to be, like we could say loading, I guess, like for example, fingers and stuff, you want to make sure they're really warm to prevent injury or to prevent repetitive strain. I'm just wondering if you guys can maybe touch base on just your thought process of warming up really quickly.
Yeah, I'm not sure how it pertains with rock climbers in particular, but I remember some research study that looked at dynamic warm up, which is like what you're talking about, where you're moving, you're sweating, you're lunge and twist, and you're inchworming, you're just moving, essentially jumping jacks. It doesn't really matter, right? Compared to either no warm up or just static stretching, and it reduces injury rates by up to 33%, like a third, of just being a dynamic warm up instead of these traditional warm ups. Long gone are the days where before soccer practice, you reach down and touch your toes for 30 seconds. Yeah. Right. So you're absolutely right. We've got a pretty structured dynamic warm up in the clinic that I give people, and I give it to them to take home before they do their stuff. And essentially the key is you want to move in all three planes, right? You want to move forward and backwards, side to side, and rotational. You want to get your heart rate up. You want to be pretty much sweating, before you're actually getting on the wall to go climb. And like you said, you're getting some synovial fluid to move through the joints. It's going to help lubricate your joints. You're getting your muscles primed. Your nervous system's getting primed. Everything's going to be ready to go, and your chance of injury is going to be, your performance is going to go up, and your chance of injury is going to go way down.
Yeah, totally.
I don't have a specific sort of exercise protocol, but I would sort of confirm all of that dynamic warm-up stuff. I think for climbers, probably the biggest concern would be those A2, A4 pulley injuries. So you really want to make sure that your hands are really warmed up, because you can do a really aggressive load.
I have a warm-up.
Do you? So yeah,
you take your thumb on top of your fingernails and you flick outwards, and you start down low underneath your heart, and then you keep flicking, raise them above your head, and then bring it back down again. And then you can, once you like get a little bit of a pump going in your forearms, you can then start to flick individual fingers. So you start to flick just your pinkies, then your ring fingers, then your middle fingers, then your index fingers. And then you go back to doing all four again. And your goal is to literally get your forearms pumped, and then you let them rest again, and then you're ready to climb. And that's been my big protocol for warming up my tendons and my hands, especially on a cold day. Because I have popped both ring finger pulleys before from jumping on a 511 in the cold with no warm up, and it was like one of the first moves off the ground. Pop, it was gone.
Yeah, because this is another one that I found to be very, very interesting. So I love this statistic. So those A2, A4 pulleys, they're designed to withstand 400 newtons of force, right? But a crimp alone can generate 450 newtons. So you are already, like, if you were to just go full crimp, like, you're already about 40% over structurally what they're designed to handle. That's an insane statistic to me. And like, I can't believe it doesn't happen more often, frankly, to like the beginner climber who is so pull heavy versus footwork. I couldn't imagine, like, I don't know how I made it through like a bouldering session as a beginner and I didn't pop my tendons. Like, looking at that statistic blew my mind.
I think it'd be specific edges, and actually like crimping is specific when your thumb's going over. So, but as a generalization, I do agree with you. And the reason I wanted to bring up this warm up is like, you know, sometimes I like going to the gym and not to be too judgmental, but it's pretty interesting to people watch sometimes. Sounds a little creepy or something, but like you see people's forms or how they work out or what they do. And this application could go to a climbing gym. It can go to a rec center or like a, you know, fitness facility or whatever. And you can generally kind of tell when people have like a pretty good understanding of physiology and injury prevention and the way they operate. Whereas like the majority, like in my experience, I'd say about 90 to 95% of people just come in, zero warm up. They either jump right on the climbing wall or they bench press right away or do whatever. There's no stability work involved. There's no warm up. And it's just like leading to like poor motor mechanics, probably injury and all these things. So yeah, I just thought we should touch on that.
Yeah, no, really powerful stuff.
Very much so. And like, I mean, those guys can get away with it for a while, right? But they're probably creating a lot of these little micro traumas that are getting them closer and closer to that macro trauma, right? So that's why it's tough sometimes, because people don't realize that what they're doing isn't good for them, right? And all of a sudden they go and do that exact same thing for the 50th time, and that's the one that does them in. You know, and they look at you and they're like, well, what I do that stuff all the time. Why did this one hurt me? You know, and it's like, well, this has been in the works for a while, probably.
Yeah. But the froth is real. Like, everybody's excited. They want to do these things. And like, who wants to do finger flicks? Like,
I do.
Right there.
I do.
Everyone circle up. Finger flicks.
Yeah.
But I mean, it's true. Everything that Kevin alludes to is totally true. It keeps us in business.
Yeah, well, I think that's a great place to kind of move on, and maybe if we can just touch on the traumatic injuries here, you know. So
Matt, I'm looking at your little sheet here on traumatic recovery, and I feel like we are coming close to the 2-hour mark, so I think time's a little bit limited. But I think we have covered a lot of stuff, kind of in terms of the recovery and a lot of this stuff in terms of the repetitive strain injuries and preventing that stuff kind of transfers over. So whatever you have specifically for traumatic injuries that you'd like to cover, I'd love to hear it. And then I think we talked a little bit about return to sport protocols.
Yeah, that would be great.
But yeah, just kind of rolling into that and kind of closing off the entire conversation, ending with kind of giving people a vision for how to return back to the sport hope if they currently are dealing with
for sure. Yeah, you'll be all right. So I think most important that I added in there were, again, some statistics, and I don't want to just live in the statistical world, but I think it provides perspective. So they estimate, Cole et al. Estimated like 10 to 39% of all injuries are from a fall, and 43% of those fall injuries result in surgical interventions. And finally, 20% of those injuries are ankle contusion and fractures.
Who would have
And
thought?
so, yeah, go figure. So, I'm on the right place. We're here for you guys. And I think the most important thing from a standpoint of maybe some of your decision making is that you get to the 6 meter or 20 foot mark, and your odds of fracture by fall are 2.5 times. And a sprain is 3.5, almost 4 times more. So if you're out there trad climbing, and you don't want to necessarily be thinking, oh, I've got to prevent myself from an ankle fracture. It's helpful to maybe put in, that Jesus nut before the 6 meter or 20 foot fall, right?
Yeah,
I think I'm using that term.
Probably the Jesus nut, the Moses nut. We just keep going down prophetic names, you can do this all day. Horus, we got the Horus cam.
Isn't that what they call the first nut after like the anchor? Is the Jesus nut? Isn't that right?
Yeah, no, it's totally right for sure.
You climbers are a weird group, man.
That's for you guys out there. It's like that's the one that'll save you from what I think is a factor 2 fall, basically when you're building an anchor. But if it's a ground fall, it's the same concept. Like maybe just consider those first 6 meters to be valuable in a decision-making process. So I think that would be probably the most important thing. And then Kyle's alluded to this in previous ones. He made a sound decision because he could in regards to surgeon skill. So I think from a standpoint of a physical therapy, physical therapy recovery, traumatic surgical injuries or even sort of traumatic non-surgical injuries are really kind of paint by numbers, right? So it's like if it's weak, we strengthen it. If it's tight, we stretch it. And you sort of restore yourself through just activity. Surgeon skill plays a huge role, though, because they're the ones, they're based on conversations I've had with my surgeon friends, like their objective is to restore sort of anatomy. And so they're inserting screws and rods and all these things to make it so that it's anatomically similar to what it was pre-injury. And that's all surgeon skill. And at the end of the day, as a physical therapist, we have it pretty easy if the surgeon did a great job. And so making that decision, if you're capable of, to hold off and get a surgeon that is skilled and is familiar with the procedures just sets you up perfectly for a much better recovery. And then patience. I think patience is the number one struggle for most people, especially active people coming off a traumatic injury. It just takes forever. And the way I sort of tell people to manage their day is I say it takes twice as long to do half as much. So you're 25% efficient from where you were, the day of the injury. And that just kind of gives people a structure and gives them space to forgive themselves for maybe not doing everything that they thought they could, because there's so many factors that are going on in an active healing process. I think of it like as a bank account. And like you start your bank account at 100 and, just like $35 of that bank account is like breathing, digesting, normal stuff. And then, so you're already at like $65 for the day. And then your healing is another $25. So now you're left with $40 to spend the rest of your day. Like, how do you spend that to feel like you're accomplished and you're sort of in it? Does that make sense?
Yeah.
So, and then that's sort of kind of how I shepherd people through this recovery process. And it's universal. And, their way to spend their money or to feel efficient is a lot different across the spectrum. So it's somewhat applicable in my mind.
Totally. Yeah. Well, I think then, I think we can go on to this next topic here, which is, like Kyle said, getting back to sport. This is the fun part, right?
Yeah.
This is what it's all about.
This is exactly
the best part of the job.
This is all Kevin. I am going to sit back and learn. So I'm quite interested. I mean, Kevin, don't be afraid. No, he has like this sports certification that is like really hard to get. He's doing his fellowship. This is the man. So I'm sitting back and enjoying.
Well, I mean, I've learned a ton from my job up in Spokane, working hand in hand with the strength and conditioning coaches. Those guys are so good at what they do. And there's definitely some crossover between what we do and what they do. And working hand in hand with those guys, I mean, that's just like the bread and butter, So it's really fun to get people from an acute injury back to where they were, work with the strength and conditioning coaches about getting them now maybe a little stronger, maybe a little more active than they once were, running a little further, doing a little bit more sport-specific stuff, and then hand it over to them and watching them just take it and run with it. But yeah, I mean, this is a big part of my passion in the PT world, and I think a couple of things to really consider from really the beginning is continuing to stay active in other ways. Working the other side. If you broke your right foot, do calf raises on your left foot. There's actually this cross education stuff where you can work out one side and the other side actually gets stronger, right? And it's all neurological based. The muscles aren't actually getting stronger, but your nervous systems learn how to fire things harder, right? And then as you progress more and more into being active and getting back to your sport a little bit, but you're not quite ready to go. What I always tell people is like, you got to prove it. You got to prove. We're not going to ever sit you on the table and exercise you on the table and then say, okay, you're good to go for it. Like it's a very progressive, slow at times, stepwise progression to get people back to doing what they want to do, a little by little by little. As far as like specific, protocols, most of these are designed for, soccer players, basketball players, runners, kind of your traditional sports type people. There's really none that are specific for rock climbing, but going over just a couple classic lower extremity protocols for return to sport. First thing you need is a quiet joint, meaning a joint that's got no inflammation. It's got zero pain at rest or with any of the rehab you've already done. Like that, you just need that. Pain changes the way you move. If you're trying to jump and be active through pain, you're more susceptible for re-injury, right? That's baseline, right? Your strength needs to be symmetrical, right? And some of that's subjective because we're just testing with our hands. Although I would suggest if you're a high-level athlete and you're working with the PT should have some sort of measurable way to measure your strength, right? A lot of them use these little crane scales that you can rig up onto a table, and you're pushing as hard as you can to that crane scale or pulling as hard as you can on the crane scale, and it actually gives you a number, right? So you need to have these numbers of output of strength that are totally even from side to side. Not 90%, not 95%, like 100% even, if not stronger, right? And then you can get started in more of the specific, more kind of exciting stuff. So for lower extremity, one of the big things we do, after injury, you're going to lose a lot of power, right? Power is how fast you can move and how fast you can produce force. So jumping is a good way to measure power. And the classic return to sports protocol for lower extremity injuries are these 3 hop tests. There's a single leg hop test for distance where you jump with one leg as far as you can. You got to stick the landing, right? You take the best of 3, compare that on right and left. It's got to be, literature will say like 90, 93% is good. I'm more of like, you got to be 100%. You got to be right there. So that's one single hop. The next one is a triple hop. You're on one leg. You're hopping 3 times right in a row consecutively, and you stick that last landing. Take that distance. Compare it right and left. The third one is a crossover triple hop, where you go from one side of a tape measure on the ground or a piece of tape on the ground. You cross over to one side of the piece of tape, cross right back over to the original side, and then cross back over to that last side again. Measure right and left. Right, pretty straightforward. Go ahead, Matt.
Kevin, I have a quick question. With that, are you taking on the triple hops? Is it going to be symmetrical for every hop, or are you more concerned about the end game?
The total? Yes.
The end game.
Yep.
So even if there's asymmetries in the middle hop, we're still all right with that return to sport to the end game.
Absolutely. Yes.
Okay.
Yep. You're taking the very last final measurement of where they land, right? And then one that I'll add sometimes too, especially if they're in a sport that's a lot of lateral movements, is just a side hop, like a lateral hop, right? They're facing sideways and they're jumping sideways, right? And that same thing, you just measure the distance. One thing that I think that, it's pretty easy to put someone through that protocol, and just see what their numbers say and calculate the numbers and what percentage they're at. But another thing I really pay attention to is how they're moving and how they're landing and how they're jumping. There's these, you see people that don't quite have the best eccentric strength on a leg, and when they land really stiff-legged. We call it like ligament dominance, where you're relying on your ligaments to absorb a bunch of that load from you landing, compared to someone that lands and they're a big shock absorber. You see them, their foot hits the ground, their knee bends, their hip bends, they stay tall, and this big, huge shock absorber absorbs all that force and then, pops them back up. And so that's a little bit more of a subjective art of it. A little bit is looking at how somebody moves, making sure they're using their muscles properly and they're landing properly without putting their lower extremities at further injury, right? And pulling out the iPhone and doing a slow-mo video is a sweet resource to have in the clinic, right? Like we didn't have that, 10 years ago, and now we've got it, and it's such a huge advantage to have. So that's kind of your standard lower extremity protocols. Obviously, you kind of tailor to someone's a runner, you're going to do more running stuff and so on and so forth. But for the purpose of this podcast, upper extremity protocols are almost all geared towards throwers in the literature, right? Because that's a huge percent of population of return to sport testing is in throwers. I think the one that really applies to climbers, though, is this modified pull-up test, where you can imagine laying on your back under a Smith bar or even just a rack, really, and you're reaching your hand straight up towards the ceiling, and the bar is just like a couple inches past your fingers, right, above your fingers. And guys will put their heels up on about an 8-inch box. Girls will put the box up behind their knees to make it a little easier, right? And you reach up and you grab the bar, so you're on your back, you're grabbing the bar, and you're pulling that bar until your upper arms are parallel with the ground, right? Not all the way bar to chest, a little short of that. And you're going for reps, right? You're trying to get as many reps as you can before you break form or you can't pull yourself up high enough. And there's been some literature done that kind of has normalized numbers on what you should be achieving. And it's kind of interesting that for men, if you're between 18 and 22, you should be getting 11 of those reps. If you're men between 23 and 27, you should be getting 12. 28 and 32, you should be getting 9. So it starts to drop a little bit. 33 and 37, you should be getting up to 18, which is blowing the younger group out of the water somehow. So apparently between 33 and 37, you're supposed to be a lot stronger than you were when you were between 18 and 27, which I thought was interesting.
How many can you do, Kevin?
Oh, I can do probably like 50 or 60.
Million two.
That's right. I don't know if you heard me counting, but I did over 1,000.
Your wife walks in, 1,003, 1,004.
Yeah. Exactly. No, it's been a while since I put myself through that one, and probably for good reason. I was probably but girls, women between 18 and 22 should be getting 4, 23 to 27 should be getting 4.5. If they're 28 to 32, 5. And you can look these numbers up if you wanted to, but I mean that's from the upper extremity stuff. So much of the testing is throwing, which is going forward, right? You're accelerating your arm, whereas climbing, you've got to pull, right? And it's so much of a pulling sport. So I think that modified pull-up test is going to be probably the best return to sport test for climbers, on top of all the normal range of motion strength stuff I already talked about.
So this was you're lying down, feet on a box, and then you're pulling the bar just to your chest,
yes.
Right? Yeah. Okay, gotcha. So there's a whole bunch of core and posterior chain engagement, and then you're pulling it in. Okay.
Yeah.
Sweet.
That's quite common. That's quite common in the personal training world, right? Like performance kinesiology stuff. Like those kinesiologists, they fully believe. I've seen it just personally. I don't know anything about it, but
it's an easy thing to measure, because you're just measuring reps, but it's a lot easier than pull-ups. Some people can't do more than 1 or 2 pull-ups, so it's hard to measure change, because it's like, okay, you went from 2 to 2.5 or 2 to 3, whereas this is you're going from 11 to 17. So I think that this is a little bit more useful in the clinic.
For sure. There's a really cool ice climbing progression that is exercise similar to that, and it starts off with like a progression of like you're like holding TRX handles and you're doing the similar pull with your legs at 90, and this progression will go all the way to having an ice tool in one hand and both legs on an exercise ball, and then you're pulling with full rotation all the way to the top, and then that can progress to having weight as well. So it's a really, really cool exercise. I've done it a whole bunch in programs, but it's a lot.
Yeah, I like it. And really, I mean, you could just kind of you could apply that stuff to yourself, right? Like you can take that and just say, okay, I'm going to go with one arm, and see how many I can do when I'm pulling with one arm versus I can pull with the other. And it should be 100% equal, right?
Yeah.
And same thing with totally. Some of these other ones are like taking a medicine ball, sitting in a long sitting position, taking a medicine ball and just shot putting it as far as you can on one side and measure that distance. Shot it on the other side. It's got to be the same, even if you're non-dominant arm, right? So it's just symmetry, right? Symmetry and a slow progression back to full activity.
Yes.
And confidence.
Symmetry, slow progression, and measurable, obtainable like goals and standards to actually certify, like some of these things, I don't know if ambiguous would be the right word or something. Like obviously they pertain a lot more to like specific sports, but the principles still abide about like tissue health, body health, strength, symmetry, right? And just also having this, you're removing guessing out of the equation, right? Rather than just being like, oh, well, the surgeon told me it's been 6 months and I feel okay. So like, I'm going to go back to playing soccer or, I'm going to go back to climbing. It's like, well, like if you have a baseline of where you were at before and now you can do half as less, you can guess that most likely you're not fully healed and you're actually weaker, which means you're more injury prone, right?
Yeah. And there are there are a lot of consumer products that Kevin alluded to. Those biomechanical apps, they're great. And, I've done a lot of remote training with people where they'll send me videos and I can just look and add angles to it and you can see the asymmetry and then you can put numbers to it and it really reinforces. And there's a lot of evidence out there about visual reinforcement being a very powerful motor control and motor learning tool. And people can change it remotely. Like you can change your running style on a treadmill remotely based on this sort of app feedback. It's really neat stuff to see.
Super cool.
Oh, I guess the question I have, with this topic is return to sport, and we're throwing out some metrics and we're throwing out these numbers. Is this more of like, because to me those numbers aren't like, okay, I hit these numbers, now I can play my sport again. It's more of I hit these numbers, now I can assume I'm back to quote unquote normal, and I can assume I'm out of some sort of danger zone.
It's comparing you to people of your gender and your age group, right? So it's normative data. It's not symmetrical data. It's not, it's not comparing you to your old self, right? So so it's useful, but it's not everything, right? You take it with a grain of salt. Like Max was talking about, you got to take your history into it, your prior performance into it. Where are you at from 0 to 100% based on what you were before your injury, and use that as a guide on how hard to push yourself as you get back to it.
But someone could potentially start climbing before they can do whatever number you mentioned of those back pulls. It's not it's not a barrier to reach before you can return to sport. It's more of just a comparison
right,
to
exactly.
normality.
And that's what kind of that, you got to prove it, right? You got to get them on the wall and start climbing, and you might do the easiest pitch and you're doing it for 5 minutes, and that's day one. Let's see how you respond. Let's see if you're sore, like I was talking about earlier, now 1 hour from now, tomorrow, and then from there, let's do 10 minutes, and then let's move on to the harder one. Let's go 15, 20 minutes. And it's just really it's really logical. Like we're not recreating anything. It's really kind of boring. And when I explain it to people, they're like, oh, well, duh, like that's the most logical thing possible. But you just have to make sure and follow through with it. Like that's the thing. Is you'll go through times where you'll be like, okay, I'm midway through this progression. I'm doing this moderate, climb, and I'm feeling really good. I'm going to go for it, man. I'm going to go for the hardest climb in the gym, and Like you've got to rein yourself back a little bit and just take it in that really stepwise progression to make sure you prove it every step of the way.
Yeah, and Kyle, these protocols are not predictive, right? They don't say, oh, because you can do these things, now you're going to be good again, right? Like there is a big space between, being able to perform and performing. And so that's the tough thing. And you can do things, but suboptimally. So when you think about climbers specifically, what's great is it's a graded activity, right? Like you're a 513 lead climber at your max, right? So could you be a 5'8" top roper during the active recovery process? Sure. I mean, you can speak of that, how you, even though we didn't reach these benchmarks and we may not get to them anytime soon, can still go back and perform your sport. But there could be potential consequences that need to be discussed between you and your provider, or just with you and yourself.
Mm-hmm. I guess I just wanted to add some context to our topic, which is return to sport, and these exercises and benchmarks that you were kind of laying out, so that someone might not assume like, okay, I have to hit these before I even get back to my sport.
Yeah.
That was all I was trying to add context to. But yeah, Kevin, you said there was something you were about to add.
Yeah. One of the final components I'll give to somebody before totally releasing them back to their activity is what we call the fear avoidance belief questionnaire, right? And that's just like they fill out this piece of paper that's a bunch of questions, essentially gauging their fear of injury or fear of re-injury, because I've had people that have been physically 100% good to go, past all these tests. I've thrown everything I can possibly think at these people, and they just don't have it quite yet. They're just not ready to go. They're mentally not there, right? And that's somebody that, okay, well, let's stick to the plan then. Let's get back in the gym. Let's take it a little slower, X, Y, Z, right? And that little bit of confidence, I think, it can put people at a risk of, or lack of confidence, I should say, could put people at a risk of re-injury, like for a good example is like 6 or 8 years ago, Derrick Rose, his basketball player, his stud basketball player in the NBA, tears his ACL, rehabs all year. He's on the Bulls, right? The Bulls are getting into the playoffs. He's starting to finish up his rehab, doing his return to sports stuff. He's passing everything. He just refused to get back in the game. He just said, I can't do it. I'm not mentally ready. I'm too fearful of re-injury. They held him out. Of course, all the Bulls fans are pissed, right? But he comes back in summer league, tears his meniscus, right? So he still wasn't quite. I mean, accidents happen. Don't get me wrong. You could rehab somebody perfectly. They could have zero fear and still re-injure themselves. But you kind of wonder if in that case, not having the confidence, being a little nervous, being a little scared, playing hesitantly, can all contribute to your risk of re-injury and not being ready to go back completely.
There's a level of having intuition.
Mm-hmm. Yeah, absolutely. Yeah. Just your own. You got to reflect yourself, and say, okay, physically the doc and the PT says I'm good, but am I good? Let me be honest with myself.
Yeah, and there was a study I was exposed to in graduate school where orthopedic surgeons looked at traumatic knee injury in football players, and they used fantasy football scores. And what they saw was, they go through everything. That player year one produced about 50% of the fantasy points that he produced the year before his injury, and then by year two he was back to normal production. And so that's something I also sort of reiterate with my patients, is that even professional athletes, they may not perform to where they were before, but they eventually get back there. And this circles back all the way to that biopsychosocial aspect. Like all of these intertwined belief structures, anatomy structures, everything comes together, and it does add this really sort of complex return to sport and recovery aspect that, has to be examined a little bit more in depth by the patient.
Awesome, guys. I think that's a perfect place to end it. If you guys are okay. Kyle, did you have anything else?
Yeah, I have one more thing for the listeners out there. I live my professional life by this. It's real simple. It's like, we'll rip up in applause, I guess afterwards. But I do believe this. I think movement can replace medicine, right? Like we understand that, but medicine can never replace movement. So just get out there and do these things. And I think that's probably my last sort of thing for the listeners.
Yeah. Awesome. Well, Kevin, Matthew, thanks so much for coming on. And it's been a pleasure talking with you and stuff. And, who knows, maybe we can have another conversation in the future.
Yeah, keep us in mind.
Yeah, man. Yeah. Thanks for having us. It was a lot of fun, and good luck to both your guys' recovery and getting back.
Good luck with the house and the kids, my friend.
Thank you.
Yeah. Appreciate it. Yeah. I'll take all.
Good luck, guys. Thank you again, Kyle, for reaching out, and I appreciate this opportunity. And Kevin, thanks for joining.
Yeah, it was fun.
Yeah, nice meeting you guys as well, man.
Yeah, definitely.
Max, nice meeting you.
Take care.